Hello, and welcome to Group 1's presentation on Duchenne muscular dystrophy. To begin, we'll start with the disease summary. Let's get started with general information. Duchenne muscular dystrophy, or DMD, is a treatable but incurable rare genetic disorder characterized by progressive muscle degeneration and weakness due to the alterations of a protein called dystrophin that helps keep muscle cells intact. The symptom onset is in early childhood, usually between ages 2 and 3, but recognized medically between the ages of 3 and 6 years. The disease primarily affects boys, but in rare cases it can affect girls. Some girls are also carriers with mild symptoms. The diagram on the right shows how children from a mother who is a carrier of the disease genetically and a father can affect their children, with red representing the disease and the shapes representing their offspring. Below, there is a boy with the disease at the ages of 2, 8, and 15, and how the disease has gradually made itself apparent with lordosis or swayback of the spine, the need for a wheelchair, and enlarged calf muscles. Here it is clear to see the general outward signs of the progression of the disease. Once again, this is just a general infographic with some basic information about the disease and the diagram depicting how the disease appears in boys of growing age. Continuing on the general information section, DMD is one of 4 conditions known as dystrophinopathies, which will be discussed in more detail later. The human dystrophin gene is the largest known human gene that provides instructions for making the protein dystrophin. Dystrophin is a protein located primarily in the skeletal muscles to be used for movement, and it is also found in the cardiac muscle of the heart. Additionally, small amounts of dystrophin are present in the nerve cells in the brain. More specifically, dystrophin is one of the many proteins found in the sarcolemma, which is the plasma membrane of the muscle cell, and is surrounded by basement membrane and endomysial connective tissue. The sarcolemma is the site of action potential conduction, which triggers muscle contraction. In skeletal and cardiac muscles, dystrophin is part of a protein complex that works together to strengthen muscle fibers and protect them from injury as muscles contract and relax. The details of how dystrophin works specifically will be discussed later in the presentation as well. In the illustration depicted here, there are yellow circles linked together which represent the dystrophin protein where the actin filaments are attached to within the muscle cell and interacting with the sarcoglycan complex making up the sarcolemma. Here it is evident that dystrophin is involved in a complex system of proteins and how it actively works to reinforce the muscle fibers. So yet again, here is an illustration of the structure of muscles at the cellular level, and we want to emphasize the dystrophin protein, its interaction with actin filaments, as well as its role in the muscle cell. Next, we'll be discussing the history. On to the historical background. The first historical account of DMD was reported by Professor Gaetano Conte and Dr. El Gioja in 1836. They described 2 brothers with progressive weakness starting at age 10. Then they mistakenly diagnosed it as tuberculosis. Then, in 1852, Edward Meidron reported a family of 4 boys, all of whom were affected by significant muscle changes, but had no central nervous system abnormality when examined at necropsy. He even went on to suggest that a sarcolemmal defect was at the root of the disorder and that it was genetically transmitted through females and that it affects only males. As shown here, a painting of Dr. Edward Meidron and his scientific research, including his findings on muscular dystrophy, in print. Continuing with the historical background of the disease. Then, DMD was described by French neurologist Guillaume Benjamin Armand Duchenne in the 1860s, but it wasn't until the 1980s that some light was shed on what the cause of the disease was. But because Duchenne was already held in high esteem for his work in using electric currents in medicine, and for his contributions to the understanding of muscle diseases, they named the disease after him. Finally, in 1986, the Muscular Dystrophy Association supported researchers identified a particular gene on the X chromosome that, when flawed, or otherwise known as mutated, leads to DMD. In 1987, the protein associated with this gene was identified and named dystrophin. Here is a photograph of Dr. Guillaume Duchenne, selections of his many clinical works, and an image of a test subject undergoing ferretism to create a shocked facial expression, and the MDA logo. Now onto the natural history. If left untreated, those with the disease may face the following: the inability to walk and/or shortening of muscles and tendons, further limiting movement, breathing problems that can become so severe that assisted breathing is necessary. Curvature of the spine can be caused if muscles aren't strong enough to support its structure. The muscles of the heart can also be weakened, leading to further cardiac problems and also difficulty swallowing, with a risk of aspiration pneumonia due to the point where a feeding tube is necessary. Here we have a boy in a wheelchair and an illustration of another boy who's being fed through a feeding tube. Let's discuss the prevalence. In Europe and North America, the prevalence of DMD is approximately 6 per 100,000 individuals, while worldwide it is one of the most frequent genetic conditions affecting approximately 1 in 3,500 male births. Due to the fact that this is a genetic disease, there aren't places in the world where DMD is most common, but rather a race. It has been found that since DMD is the primary cause of deaths in young males with MD, mortality rates are a reasonable proxy for the relative difference in racial prevalence. As a result, it appears that DMD is significantly more common in white males than in males of other races. The photo to the right is stating that the coverage of the disease worldwide will increase by about 32% by 2023 based on current data trends. Depicted here is a young Caucasian boy and the forecast of how many individuals in the population will have the disease by 2030 based on current data. Lastly, for the disease summary section, the presentation of the disease. DMD is characterized by weakness and wasting, other known as atrophy, of the muscles of the pelvic area, followed by the involvement of the shoulder muscles. Weakness typically starts proximally in the lower extremities, then moves distally. Weakness in the upper extremities also tends to appear later. As the disease progresses, muscle weakness and atrophy spread to affect the trunk and the forearms, around the hips and the shoulders, and gradually progresses to involve additional muscles of the body. In addition, the calves appear enlarged in most patients. This means that fine movements, such as those using the hands and fingers, are less affected than movements like walking. This slide portrays the areas in the body that are most affected by Duchenne muscular dystrophy.
Possible causes. DMD is caused by a mutation on the DMD gene on the X chromosome. The gene regulates the production of a protein called dystrophin that is found in association with the inner side of the membrane of the skeletal and cardiac muscle cells. Females that have the defective gene present on one of their X chromosomes are carriers for that disorder. Carrier females usually do not display symptoms because females have 2 X chromosomes and only one carries the defective gene. Males have 1 X chromosome that is inherited from their mother, and if a male inherits an X chromosome that contains a defective gene, he will develop the disease. Dystrophinopathies are X-linked progressive hereditary degenerative diseases of skeletal muscles caused by an absence of dystrophin. Lack of dystrophin protein in muscles causes them to be fragile and easily damaged. Disease path. In children with DMD, initial findings may include delays in reaching developmental milestones such as sitting or standing with no assistance. As the disease progresses, additional abnormalities may develop, such as progressive curvature of the spine. A contracture happens when thickening and shortening of tissue, like muscle fibers, causes deformity and restricts movement in certain areas. By the age of 10 to 12, most affected individuals require a wheelchair. By late teens, DMD can develop into life-threatening complications such as weakness and deterioration of heart muscles called cardiomyopathy. Cardiomyopathy can result in impaired ability of the heart to pump blood, arrhythmias, and heart failure. Another serious complication associated with DMD is weakness and deterioration of muscles in the rib cage. This can result in an increased vulnerability to respiratory infections, difficulty coughing, and ultimately respiratory failure. When muscles of the gastrointestinal tract are involved, this may result in dysmotility, a condition in which the passage of food through the digestive tract is impaired because of slow and uncoordinated movements of the muscles in the digestive tract. Gastrointestinal dysmotility may result in constipation and diarrhea. Median survival was 24 years in patients confirmed by molecular testing. Ventilated patients had a median survival of 27 years. Although survival into the early 30s is becoming more common than before, thanks to advances in treatments will be discussed later. Phenotype. DMD is classified as a dystrophinopathy. The dystrophinopathies are a spectrum of muscle diseases. Each is caused by alterations in the dystrophin gene. The most severe end of the spectrum is known as DMD, lacking complete dystrophin protein. The clinical characteristics of DMD include weakness and deterioration of any voluntary muscles of the body. In progressed stages of the disease, the heart and gut muscles will be heavily affected. What is the disease causing not to work properly, and how would this work normally? DMD is caused by mutations of the DMD gene located on the short arm P of the X chromosome. The DMD gene regulates the production of dystrophin, a protein that plays an essential role in maintaining the integrity of a cell membrane in the skeletal and cardiac muscles. Mutation of the DMD gene will result in an absence of dystrophin protein, leading to degeneration of muscle fibers. The dystrophin complex acts as an anchor connecting each muscle cell structural framework, the cytoskeleton, with a lattice of proteins and other molecules outside the skull. The dystrophin complex plays a role in cell signaling by interacting with proteins that send and receive chemical signals.
So in early stages, DMD affects the shoulder, upper arm muscles, and the muscles of the hips and thighs. These weaknesses lead to difficulty in rising from the floor, climbing stairs, maintaining balance, and raising arms. Symptoms of Duchenne muscular dystrophy. The most common form is walking on toes, large calf muscles, waddling around, muscle pain and stiffness, delayed growth, learning disabilities, falling frequently, and trouble with running and jumping. And the slide shows some of those symptoms. As you can see, the belly also sticks out due to muscle weakness all over the body. And you have thin thighs, poor balance. And it shows progressive muscle weakness on the right photo and also difficulty controlling movement. So these slides are one of the forms of treatment that you could have with DMD, which is PT, physical therapy, which can help keep muscles flexible and strong by doing physical activity or muscle exercises. Another form of treatment is respiratory therapy, which people with DMD lose respiratory strength and weakened muscles become affected during breathing or can cause infection leading to pneumonia. So some people with MD need a ventilator to help them breathe, so it's easier to treat. And it could also prevent further respiratory problems in the future. This slide is about speech therapy. So for those who experience weakness in the facial and throat muscles, they would go to speech therapy in order to better improve their muscle strength. And this photo just shows what speech therapists do. So they help pronunciate letters and help sound out words to better improve the muscles. This slide shows a glimpse of OT, which is occupational therapy for those with lost motor skills and those who need help using assistive devices like wheelchairs or even having eating utensils, which is not pictured, but OTs help develop treatment for patients with specific goals, so having improved muscles, and then they guide patients to meet their task and help them out if they do have the disability of needing a wheelchair. Surgery would be another form of treatment depending on the patient's severity of their case. Pacemakers are usually used for those with myotonic MD, which is those with heart problems, and they could also have surgery to remove cataracts or treat those patients with scoliosis. So this photo on the left shows the cataract surgery to help with vision. The photo in the middle shows scoliosis, so if they were to have surgery for scoliosis, and the one on the bottom right shows a pacemaker in the heart. So drug therapy is one of the big ones, which can help delay damage to the muscles or minimize symptoms. So glucocorticoids can increase muscle strength and respiratory function, and they actually are discovering a new type, which is being tested only on boys, which is called vamorolone. And it has similar effects as prednisone, which are glucocorticoids, but the effect is having no side effects. There is also anticonvulsants, which can help control seizures and muscle spasms. immunosuppressants, which can help delay damage to dying muscle cells, and then beta blockers, ACE, which is angiotensin converting enzyme, which can help treat heart problems like high blood pressure or heart failure associated with MD. And in the slides, it just shows some of the pills or glucocorticoids that you can take. And then it also shows the molecular structures for vamorolone, glucocorticoid, beta blockers, and then the anticonvulsant pills. And then the last form of treatment would be gene-based therapy, which is still in development but benefits in restoring the patient's gene ability to make usable proteins. And it also increases the production of dystrophin, which is the deficient protein in DMD. And here it just shows the process of the gene therapy and how they go upon it. So for the prognosis, most patients have died in their late teens or early 20s due to respiratory infections or cardiomyopathy, which has to do with the heart. And though there's been an improvement of survival up to 35 years since there's been advancement in respiratory and cardiac care, the average obviously depends on the severity of their case and the age of the person and how bad their symptoms are. But with improvements, patients can be seen with a lifespan falling between 30s to 50s. And the photo on the left just shows a diagnosis. So this is when you're more younger. So at age 2.5, the first sign or symptom is noticed. Age 3.5, a child is taken into pediatrician or family care. And then at age 5 is when you would get diagnosed. And then the chart on the right just shows statistics from the 90s. So it shows what ventilation has happened over time and how the death decreases as people tend to age. So the percentage survival of people would increase as they get older just because of the new advancement in technology that has been developed.
Thank you for watching our presentation on Duchenne muscular dystrophy. Here are our references.